Hello, and welcome to the Rosewood Institute webinar series, What's Eating You? The Doctor-Dietitian Alliance. My name is Nancy Berry. I am the Marketing Manager at the Rosewood Centers for Eating Disorders. Joining me in the studio today are Dr. Stephen Karp. Dr. Karp is the Chief Medical Officer for the Rosewood Centers for Eating Disorders. And also joining us is Debbie Richardson, Lead Dietitian at the Rosewood Center for Eating Disorders Outpatient Program. We hope you enjoy today's webinar series. At the end, I will be back to give you some instructions in order for you to get your certificate. Thank you, and I hope you enjoy the webinar. Dr. Karp.
Thank you, Nancy. I appreciate the introduction. I'll give you a little bit of background as to why I wanted to put this presentation together. I've been speaking a great deal over the past few years as I've worked with eating disorders. And what always comes up in my lectures is how important dietitians are in the process. In fact, at some point in time throughout treatment, they become the most critical professionals involved in the treatment of individuals with eating disorders. Also, I learned quickly that somebody who's malnourished is really a different animal, if you will, for the psychiatrist than the person that comes in with relatively normal nutrition and in the way that the brain works and functions completely, as well as whether there's enough neurotransmitters operating in the brain for our medications to even be effective. So, and it's similar as well as I come from an addiction and chemical dependency background, where there are a lot of mimics of psychiatric disorders in people with addictions and people that are using and people that are detoxing and so on, that after a couple of weeks of sobriety and treatment, those psychiatric symptoms and what appears to be a syndrome can actually disappear just with treatment. My experience in working with eating disorders, I see the same thing. After several weeks of doing the meal plan that our dietitians prescribe for the person, a lot of the psychiatric symptoms disappear, and it allows me to practice similarly in the way that I practice with chemically dependent folks, is to wait as long as I can to really get an accurate diagnosis of the eating disorder, or an accurate diagnosis of a psychiatric disorder, if it even coexists, once the nutritional status improves. So as we move along through the slides, let's see if we can get that working. Okay, I think we got it. The technology here eludes me a little bit. But the mental status, as I said, is profoundly affected by nutritional status, not only in the makeup of the neurotransmitter concentrations or the people eating the right foods to create the serotonin, norepinephrine, and dopamine, and so on and so forth that allows the brain to function. But also, I keep in mind that the nerve cells themselves are insulated, the electrical activity is insulated by fat cells, the Schwann cells that are the conductors of electricity through the brain, and if the person doesn't have enough fat cells in their brain, then even the transmission of the electrical impulses isn't going to work right as well as the chemical component of the brain. Some examples of that, for those of you that have some knowledge with dementia, the primary pathology in Alzheimer's disease is the lack of acetylcholine, which is the chemical that really is needed most, or is most important in memories, laying down new memories, pulling out the memories so that you can remember things, essentially. And so imagine if you don't have enough acetylcholine in your brain, that your memory is not going to work right, because those are the cells that preferentially die out quicker in Alzheimer's disease. And that's why the first symptoms of Alzheimer's disease is short-term memory loss. Early on in my work at Rosewood, I came to realize that extremely malnourished individuals have memory problems similar to people with Alzheimer's disease. In the past, I've worked in geriatric centers where I've assessed people with dementia. And some of these young people that were markedly underweight had the same symptoms as somebody that I might see with Alzheimer's disease. So again, and the other interesting component to that is after 2, 3, 4 weeks on a restoration meal plan, those symptoms go away completely. I call it the lights going on again. You can see the people cognitively start to come back and their memory functions start to improve, and now you can actually start to do the psychotherapeutic techniques with folks because their brain function and their memory is working better. Another important neurochemical in the brain is GABA, gamma-aminobutyric acid. It's your primary internal Valium, if you will. It's the calming or inhibitory chemical. It's the primary inhibitory chemical in the brain. In every area of the brain. If you didn't have enough GABA, you'd have seizures because the electrical activity would be out of control. You'd be so anxious you couldn't contain yourself. I think it's responsible for what are three symptoms that are very common for people that come into treatment, which is high anxiety, insomnia, muscle tension, headaches. Very common in the folks when they first come into treatment, and again, that resolves very, very nicely when the people follow the meal plan for several weeks. But GABA, again, is the primary anti-anxiety internal chemical, your own internal Valium, and if you don't have enough of it, you're going to be very anxious. It takes glucose and sugars to make GABA, so people that might be even preferentially restricting carbohydrates, well, when in this day and age of Atkins and so on, carbohydrates are seen as the bad food, if you will. Many people are preferentially restricting that when they come into treatment or have been doing that for some time, so they're very highly anxious. They're basically creating their own anxiety disorder in themselves by not having enough GABA in their brain to calm themselves down. So those are some examples of things that I've learned as I've gone to lectures on nutrition and neuropharmacology, some of the relationships that seem to make sense. So again, as a psychiatrist in eating disorder treatment, I have a joke with my dietary staff that it's easy to be a psychiatrist in acute phase of eating disorder treatment and the restoration process because I put my feet up on the desk for a couple of weeks and let the dietitians do what they need to do so that they can prepare a person to be ready to for me to assess and to really know if there's a comorbid psychiatric condition other than the symptoms of malnutrition. So my experience has been, and again it parallels my experience working in chemical dependency setting, is to wait several weeks, let the meal plan do its job, and then I can really be more confident that what I'm seeing is a psychiatric syndrome if I'm seeing it, or watch the symptoms improve over time. The medication piece is interesting to me. If you look at the literature, there's really only one medication approved for the treatment of eating disorders, and that's fluoxetine or Prozac for bulimia. Outside of that, and that's been around for 20 years. In the last 20 years, nothing new has come to be proven by good evidence and research that it has a positive effect on people with eating disorders. A lot of patients get in to see docs that may not be so specialized in eating disorders. I have to admit I had no knowledge of eating disorders until I came to work at Rosewood and had to learn on the job. I believe that still psychiatric residents aren't being given a lot of exposure to eating disorders. Consequently, we're kind of out there trying to figure out what to do. So in an attempt to be helpful, I think a lot of docs prescribe medications that typically would work for depressions per se, and they don't work because it's really a malnutrition-related syndrome that they're seeing, so they keep pushing the doses to higher levels. So I'll see people come in on multiple meds at high doses, and we certainly spend a lot more time tapering and getting the medication out of the way and let the food work, see what we have after a period of time, and then if there's still depressive symptoms present, certainly go ahead and treat that. Let's see. The other part to keep in mind too is the malnourished person is going to be more sensitive to side effects as well. So we'll see a lot of folks that are complaining more of side effects than any beneficial effects of the psychiatric medication in the early phases of treatment. Talked about the malnutrition mimics. It's just a repeat with the acetylcholine and the GABA. Again, these aren't scientifically proven things, but just in the years of working with folks and seeing these things consistently and then learning about the foods that you need to eat to create these chemicals, it started to make sense to me that if we allowed the food to do its job, maybe they wouldn't need psychiatric medications. So bottom line for me is, at least in the first few weeks, if not longer, in the treatment of somebody with an eating disorder, food is the best medicine. And with that, I'm going to turn it over to Debbie to talk a little bit about, or a lot about, the focus of the dietitians at the same time.
Thanks, Dr. Karp. He's done a really good job of laying the foundation, and now I'm going to build on that foundation and give you some of the specifics that we as dietitians would do in an inpatient setting, a partial hospitalization setting, an intensive outpatient setting, as well as just an outpatient setting. So we've really got 4 levels of care here, and we'll be talking about all 4 and helping you to understand exactly how we're using food as medicine, and then how this plays out in the details of the meal plan and the treatment plan revolving around dietary. So food is always the best medicine, and it doesn't matter whether you're in the eating disordered world or you are in the real world, the regular world. Everybody, if they're well nourished, is going to operate at a much more optimal, healthy viewpoint. And so we're going to be focusing on inpatient initially, and we've got the 3 different types of eating disorders that we would be treating: the anorexic, the bulimic, and the binge eating. And when we're looking at the anorexic client, we're really looking at initially refeeding. And then again, as Dr. Karp is saying, we can go from there. With the bulimic client, we've still got nutrient deficiencies. We may not have weight issues with a bulimic client. They may be in a normal weight range. They may be overweight. They could be underweight, but more likely it's going to be normal or over. We still need to restore them. They've got a lot of different imbalances. And then as far as the binge eating client, the weight is usually going to be in an upper level of normal to a very high range into obesity. And we want to definitely try and rebalance them. They typically are eating just certain foods that are going to accompany their binges. And so we need to get all food groups within their menu so that they can, again, rebalance. One thing that's going to be permeating throughout any level of care and also any eating disorder that we're treating is the need for hydration, because again, whether we're talking about the transport of nutrients, cognitive functioning, just the cleansing of the body, hydration's got to be there, because that's also going to definitely affect the ability for that person to think very clearly. So as we move ahead, let's focus on first the anorexic client. And as you've heard us use the term meal plan, let's talk a little bit more about what that really means. We're looking at what I would call a cast for a broken arm. So you've got a patient here that is clearly not eating what they need to. They're severely underweight. In an inpatient setting, we can see clients that may have a 9 or 10 BMI, and that's hard to imagine. I mean, you're looking at skin and bones, very, very thin, frail person that's not able to think clearly, make any kind of logical sense out of any reasoning that they have going on in their mind. Oftentimes it's difficult to gather their thoughts. So we're looking at the meal plan being very much foundational initially and remaining foundational throughout their treatment. So it's very much like a cast that supports a broken bone. And you wouldn't just say, well, I'm just going to use the cast for this week and then I'm going to take it off, and I might use it a couple days next week. But the cast remains the foundation throughout the treatment. And oftentimes, once they have met recovery and they are out leading a normal life, still you're going to find people that are going to be following a meal plan, so to speak. So what exactly is this? They have been very rigid in their thoughts as an anorexic client. They have distorted beliefs around food. They've been limiting foods. They may have fear of carbohydrates. They may have fear of proteins. They may have a very limited intake of only maybe 10 to 15 foods at all. So we're going to provide them some consistency, and it will probably start off very slowly, especially when you're looking at them being at a very low BMI. Hopefully we can get 2 to 4 pounds put on in a week. What is going to happen with that cognitive function is going to be marked, and you're really going to notice that in a very short period of time as they become refed. Sometimes we do have to go to tube feeding. That will typically just happen at night if we can manage that, because we want them eating regular solid food. This is part of their fear. We want them eating with other people. That can also be very much a part of their anxiety. So we're going to try to normalize eating behavior during the day. It might be a very limited, small amount, but it's still going to be normal solid foods. We also will supplement as needed, and that might be with just a 6 to 8 ounce high calorie type of drink if in fact they need that in addition to the solid foods and they're not on tube feed. Also, medical monitoring is very much a part of the process at this point, because in refeeding you can get into some dangerous situations, so you have to move very slowly. Again, depending on how low their BMI was when they came into treatment, you're probably going to have to progress even more slowly than someone who was at, still a dangerous BMI, but maybe more of a 14, 15, 16. You run the risk of several things happening. There's edema that can take place. Remember, you've got somebody who's not used to moving through food through their system. The peristalsis, or the ability for the muscles of the digestive tract to push food through the system, is going to be impaired. It'd be the same thing as if you taped your arm to your side and you only used, say, maybe your right hand, and then 2 weeks later you take the tape off and now you start using your left. It's going to feel very weak. It's not going to have the same functional capabilities, and you have to rebuild that strength. That's the exact same thing that happens with the digestive tract and those muscles. So the person's initially going to feel very full with only maybe 2 or 3 bites of food because they have starved themselves so greatly. So you could see some protein-calorie malnutrition, which will definitely cause that edema or that fluid buildup. The dumping syndrome can be dangerous in the sense that they take on the carbohydrates too quickly. The body doesn't know how to process it, and it's like an overload, and they could faint. There could be vomiting. There could be diarrhea. It's just a shifting of the electrolytes so quickly that it causes someone to pass out. Another thing that happens when you are looking at a person in starvation is they can literally have hypermetabolism. And it's just going to be the opposite when you get to someone, which we'll talk about, into the binge eating disorder. Now you've got hypometabolism. So they're two opposite ends of the spectrum. The hypermetabolism, they're burning calories much more quickly than they can get them in. And the irony to this for an anorexic patient is here you have someone who is not interested in food, is fearful of food, has a very low body weight, and each time they restore, and then if they happen to relapse and they lose weight again, the body needs more and more calories each time to restore. So the person that's the most fearful of eating more calories is actually causing themselves to need to eat more calories as they want to restore in their relapsing times. So it is quite an ironic situation for an anorexic client. We're always going to be monitoring fluid intake, making sure that they're well hydrated, as I said before. One of the other things we'll look at in medical monitoring is, are they having regular periods, and what does that mean? We know that to get to regular, it could take 1 to 2 years for the body to restore enough. It can take months just to have that first cycle be somewhat normal. And the reason this is happening is if a person is not getting adequate nutrients, they can't make the hormones. Fat is a critical component in making hormones. And with the inability of the patient to be able to take in the right amount of nutrition, they are not going to be able to manufacture those. The body has to prioritize. And in that prioritization, it's going to say, fine, I don't need the hormones. Just keep my heart beating, keep my eyes open, keep me breathing. It's really going into survival mode. For the bulimic client, we're again going to be increasing the calories very gradually, and we want to be able to meet their needs. They may have been overeating. We may, as we're just trying to restore them, they actually may have some initial weight loss. It's not going to be significant, but it's because they're now starting to eat in balance and more at a consistent time. So we have the breakfast, the snack, the lunch, the snack, the dinner, the snack. And this is something that has not been the case for a bulimic patient. They're very much, feast and famine, and then of course the purging, and the purging can come in different forms. They may use laxatives, they may have exercise, and then of course the purging that we all think about is the vomiting. So when they start restoring, they will feel very full, which is increasing the urge for purging. So again, it's a very, very fine line that the bulimic client is going to be able to walk in order to say, okay, I know I'm restoring, but to be in a contained environment that's going to enable them to get the calories they need, keep the food in, and again, retrain their digestive tract to be able to move that food through the system and be efficient in processing that. One of the other things that is really critical in the bulimic patient is keeping their electrolytes in balance. This can happen, they can go out of balance very easily because of that vomiting or because of the diarrhea that they're causing by taking so many laxatives. We have a lot of bathroom monitoring going on. They're not allowed to go to the bathroom, and they will have a lot of support in that. As we've talked with the anorexic client, the bulimic client is going to have those gastrointestinal problems. They may have come in with a reflux type of disease. They may have esophageal tears. They may have a lot of burning all the way up into the throat, dental issues. And then if they've been a bulimic that has used laxatives, you now stifle the system to be able to have the food progress in a normal function, and that part of the system we almost have to wean off of that and again teach the system how to excrete the waste from the digestive tract. We're going to look at stabilizing the meal pattern. We're going to have them get used to eating again in a very consistent pattern. So as a bulimic, they're not eating, and then they overeat. That equates to fullness. Now they want to purge. So we're going to have to do a lot of work around the psychological impact of those feelings. We want them to attain whatever is their natural body weight, and we'll do some calculations. We'll need to establish what their set point is. We may not know that going in, but we're going to have to kind of watch and monitor and see what happens. Again, with the possibility of initial weight loss, we have to monitor that and make sure that we are progressing as their system can handle it. When we get into the binge eating syndrome, now we've got someone who has a very focused dieter's mentality. They are very much probably in a yo-yo pattern much of their lives. We've got clients now that had parents that were trying to get them to diet as 4- and 5-year-olds. And that's so hard to imagine that people would put that kind of pressure on their children. And we all see kids that are overweight, and obviously there's concern about that. These people have been given messages that are so derogatory and demeaning, very poor self-esteem. And they've been told and given a regimen their whole life. So getting them on a meal plan, they will look at that as a diet, and we have to talk about, again, that cast for the broken arm. Their metabolism is broken. We need this cast in order to heal that metabolism. So we know that their body, their metabolism has slowed immensely as they gain more fat. They're losing muscle along the way. Typically, they're not doing any form of physical activity that is of any help to them. And with the overeating, the binging that's occurring, oftentimes they are just unable to balance that, and we have to be able to help them work through that dieter's mentality. So we will work with them to set realistic weight goals. The goal initially may be just don't gain any more weight, and how can we get the proper nourishment in instead of some people might gravitate towards sugary foods, they might gravitate to salty foods or a combination thereof. And we want to be able to work with them to get all the nutrients in a very balanced way, which is something that's going to be very new for them. We'll oftentimes do an an adjusted ideal body weight range, and that's typically going to be about 130% above their ideal body weight, whatever that would be calculated at. Some of the other complications that come along with the binge eater and the obesity issue is that we're going to have diabetes. We might have COPD, high blood pressure, the hypertension. Oftentimes and more we're seeing bariatric patients, lap band patients for instance. Now we've got other problems associated with that. If they've had surgery or they've got a lap band still in place, they oftentimes have not had any type of nutrition counseling or emotional counseling, and many of them may be emotional eaters. So here we're dealing with a problem that's been tried to be solved physically through surgery or an implementation of the lap band, and in reality they never got to the emotional issues that were there in the first place. So we're encountering this much more as the bariatric surgeries increase. We've got degenerative joint disease that's very common, lots of back issues with the obese population and the binge eating population. So lifestyle changes are going to be very difficult for them, and we work a lot on trying to do that. One of the things that we'll start with is actually introducing the concept of mindful eating. This is where they're going to learn satisfaction through other means besides just stuffing themselves and feeling overly full, and using food as their medication for whatever emotional ailments that they have, the loneliness perhaps, depression. And oftentimes we can kind of equate this to the binge eater trying to fill a hole in their heart, that there's some very deep hurt and pain and shame that's going on, and so that food is meant to just keep that at bay and fill that hole. And obviously the nutrition is meant to balance off not only the nutrients from a physical standpoint, but also to teach them, well, what does it mean to pace yourself? What does it mean to actually taste flavors and textures? How do they honor their appetite? Oftentimes they're so out of touch with, well, what sounds good to me, that it's really important to help them understand that appetite is a component, and that if they can have relationships with other people and do some of that emotional work, that the appetite will come back as opposed to just hunger to fill a void. So when we're looking at all the eating disorders together, they all have some very strong commonalities. We have power that food has, whether you're overeating for emotions and medicating using the food as medication, whether it's a release of anxiety through purging, whether it's starving yourself because that's control and that's part of how I learn that my world is something, this is one piece of it that I can have control over. So what we do is we try and take the power out of the food, and we teach that all foods can fit, that with the meal plan and the balance and the consistency and that constant input of quality fuel, that they can now restore in a healthy way, that the work that they do from an emotional standpoint is complemented by the physical work that we're doing as dietitians. So we'll be monitoring again the amount and the frequency, and that will continue. We're going to challenge them a lot. We will take a look at many of the distortions they have around food, about their body. Poor body image is a constant with any of the eating disorders. We'll educate them about, well, what does a protein do? How does that work in your body? What's the benefit? What happens if I don't get it? Same with carbohydrates and fats. We will talk about the eating disorder itself and educate them on the medical consequences. We will talk about how all of these things go hand in hand and how the nutrition is really the medicine that they're going to be taking in doses as they progress through their meal plan. We want to help them understand and make it very visual by helping them think about a rainbow way of thinking. All foods fit. There isn't anything that should be denied, but it's how much, how often, and in what proportion. We'll work in healthy physical activity as they're able. We want to be able to have healthy movement in a person's life. Everybody knows that that's beneficial. But when you've got an anorexic patient that's an 11 BMI, the last thing you want them doing is moving around. So again, we have to take a look at each patient. We have to take a look at their needs at the time and be able to prescribe appropriately. We'll focus a lot on hunger fullness cues and that mindfulness that I was talking about when we were talking about the binge eaters as well. When we're talking about dietary benefits, we're really talking about containment when you're in an inpatient environment, and this is to ensure their medical stability and the ability to restore their weight or provide such structure that they wouldn't be able to duplicate at home due to the fact that they are operating at an emotional deficiency and disability at this point, and very much a physical disability with their cognitive function. So we want to be able to manage and understand the behaviors and how that's relating to their body image, what they think about their weight, the power of that number behind their body weight. We want to allow the client to begin to trust the meal plan and see that positive things happen by eating the appropriate amounts that we're prescribing as the medicine. We are challenging their coping mechanism. Their eating disorder is their coping mechanism. And as we get closer and closer to pushing all these buttons around food, whatever it is, whether it's under eating and starving yourself or the use of behaviors in purging or the binge eating, we are challenging their coping mechanism, and that can really cause a lot of distress, and that's where the work can begin, the emotional work. So we'll be giving them a lot of support to combat all the food fears that they have, really challenging those myths that are out there that people talk about. It's on the internet, it's on talk shows, newspapers, magazines, and along with dealing with the changes that's going to take place in their bodies. That's going to be a difficult transition for them. So we want to be able to help them understand that feeling full does not mean they're fat, and oftentimes that's an equal assumption for them. If I feel full, then I must be fat. And we want to be able to provide permission for them to enjoy food. This is a population that's the last thing they think about is actually enjoying the food.
So I'll pick up at this point and kind of summarize even what I said initially is because of the levels of malnutrition, even normal weight people I've come to learn are malnourished with the ways of eating in a bulimic pattern or even binge eating disorder. You know, there's just my ability to affect change or really make a difference in the use of psychiatric medication for psychiatric symptoms is limited, and I also think it can sometimes complicate the picture, especially in that early phase of treatment, so that I want to basically keep that in mind. This is very similar, again, I kind of recall or talk about the parallels with chemical dependency treatment. As long as somebody's using their drugs or alcohol, there's very little impact. In fact, I can do more harm than good by prescribing psychiatric medication. It may be that that person does have a comorbid major depression, but if they're continuing to use, my ability to help them overcome their depression with medication and some therapy really are fruitless until they get abstinent. I believe the same holds true in my experience anyway. I mean, it's just, this isn't research-based. This is based on my years of experience. As long as somebody continues to restrict, and stay detached, which helps them stay detached from their emotions and their uncomfortable feelings, or continues to use binging and purging, which typically numbs people in the same way that drugs and alcohol do for folks from their feelings when they're feeling uncomfortable. It's really hard to make an impact in psychotherapy if they're going to use their behaviors just to compensate and numb themselves out instead of explore where the anxiety comes from and make a difference. And if the nutrition isn't adequate, not really expecting the medication to make the kind of changes in the brain that we would hope. Keep in mind that when research was done on any psychiatric medication that's currently on the market, anybody that was in a malnourished state or had another psychiatric condition would have been excluded from the study. So we really have never studied these medications in people with eating disorders and other disorders and other medical conditions because they had to just have the disorder that was being studied at the time. So it's a leap of faith to think that somebody that comes in horribly malnourished is going to respond to my medication in the same way that somebody who is not malnourished. So early in treatment, I'm encouraging the patients to really follow through with what the dietitians are telling them to do and whatever medical interventions we're doing to restore their medical conditions to normalcy if their electrolytes are off and any of the other things that happen as a result of malnutrition, bulimia, laxative abuse, and so on are being stabilized by our medical staff. I want the person to adhere to the treatment plan, and I'm encouraging to do so. Pretty much take a motivational interviewing approach. I'm looking at why the person would want to get better, help them see why they want to get better, and then help them get there. So it gets back to the position, I believe, again, once the abstinence from the behaviors disappears, even before the impact medically, nutritionally on the brain itself might take effect, once they're using those behaviors again, my ability to have an impact is limited in the same way that once somebody that's using drugs and alcohol starts drinking or drugging again to control their emotions, there's very little you can do to make headway in the treatment of those underlying conditions until abstinence occurs again. So as I teach to the families and the patients themselves, once the person's off the meal plan or starts the behaviors again, I believe the wheels fall off the train, and until they're back on track with abstaining from the behaviors and the meal plan, then you could start doing the psychotherapeutic work you need to do because they're exposed to their emotions fully and their brain is fully functional, so you can expect the psychiatric medications to be effective and be helpful. The other piece that's really important that I've learned in work with eating disorders, again, it crosses over with chemical dependency. Women with addictions, high prevalence of early childhood trauma, sexual abuse, physical abuse, neglect. Same thing holds true in eating disorders, and if you refer to Dr. Brereton's studies, I would say he's the preeminent expert on PTSD and eating disorders in the world. It's pretty clear there's a high prevalence of folks with eating disorders that have PTSD as well, and when the PTSD exists, you have to treat that effectively to have effective recovery from the eating disorder. So really what we're doing in the assessment piece too, while the nutrition is improving, is really exploring if there is not everybody has early trauma, but if there is early childhood trauma and there's a PTSD syndrome existing, you've got to identify it and you've got to treat it effectively. And the other piece that we see very commonly in our ROSEWOOD programs is comorbid substance abuse. I would say roughly 70% of the folks that come into our inpatient residential settings are either fully meet the full criteria for an addiction or dependence, or abuse, substance abuse, and it often overlaps that they're using the substances for the same reason they use their eating disorder behaviors, to not feel their emotional discomfort. The eating disorder behaviors serve that purpose, and those that work in the field know that. And in the same way that the use of drugs and alcohol can numb them from emotional experiences that are just too difficult to deal with until they work it through with good PTSD-focused therapy. being an addiction psychiatrist as well, it's been known to me for years, and it's been in the literature for years, that integrated treatment is the most effective way to treat both the mental health and the substance abuse problem. Those studies have existed for 15 or 20 years now, and that treatment is superior to sequential treatment, which means you get your mental health treatment in one first, and then you go and get your substance abuse treatment first, and then you get your mental health treatment, and you're not bouncing between two systems. Parallel is where you're getting it at the same time, but from two different systems, which can be very confusing to our patients as well. But the ideal way to treat folks that have a substance abuse problem along with a mental health condition, including eating disorders, is integrating the treatment. And we have a staff that's well versed in both of those areas, and have worked in both of those areas as well. We're also sending folks to 12-step meetings. That doesn't mean all we do is 12-step work, but we find that 12-step meetings are very supportive for some folks. I tell my patients, I said, at 2 o'clock in the morning when you're thinking of binging, if you call a peer of yours that you know from Eating Disorders Anonymous, they might talk you through it and actually meet you somewhere and spend some time with you. You call the doctor, they'll say, okay, well, don't do it, and call me back in the morning and we'll see how you did. So really those 12-step meetings and those fellowships, and it's the fellowship piece that's really important, provide amazing support for folks, both from the chemical side and the eating disorder side. And I believe mental health disorders, there could be a Depression Anonymous or whatnot, would benefit from having that human connection and support outside of the medical treatment that they're receiving as well. It's an augmentation, it's not a replacement, but it's certainly something I found over the years that really can be life-saving for a lot of my patients. And another piece to add is the recent research shows that at least 30% of folks in chemical dependency treatment, in active treatment, have an eating disorder. Most of it goes undiscovered. Most of the patients don't, in my experience, don't often admit to both unless they've been through treatment for both for a while. They hold on to the eating disorder piece when they're in chemical dependency treatment to get them through the emotional issues in the chemical dependency treatment, or vice versa. So just keep that in mind. If you work in the chemical dependency field, have a high index of suspicion that you might be dealing with somebody with an eating disorder. I suggest that if you have a chemically dependent person and they're not responding, or they're kind of odd in the way that they're reacting, consider there might be an eating disorder going on that you're not aware of and they're not talking about. Touch again, I've talked about the lack of medications that can be effective. Over the years that I've worked with eating disorder folks now, I've come to appreciate there's probably more available to be a barrier to recovery that they could be taking than really support the recovery. Number one on the list is benzodiazepines. Again, a lot of our population have PTSD. Research is clear that that taking a benzo when you have active PTSD, or PTSD that keeps emerging, prevents recovery from it. Kind of makes sense that if you can't feel your emotions, you're not going to be able to process your emotions and move through that. So benzos are contraindicated in folks that have diagnosable PTSD. And the other thing is, I look at it as a parallel. Again, this is not based on research. This is what I see in clinical practice. But the eating disorder itself is an anxiety disorder almost. I mean, when they face food, anxiety is the first response. But taking that anxiety away with a pill and not letting people process and move through it, which is the typical treatment of most anxiety disorders. Most anxiety disorders don't respond to benzodiazepines. OCD doesn't. Social phobia doesn't. I could go on. The more chronic anxiety disorders do not, and we use SSRIs and other antidepressants for it. But generally speaking, anxiety disorders outside of generalized anxiety disorder, I guess you'd say, don't have good responses to benzodiazepines. People end up needing more and more. Of course, there's the addictive quality to it as well. But my experience is it really prevents people from overcoming their eating disorder. What we're doing in treatment is we're walking people into their anxiety that then they use their eating disorder to overcome so that they can face that anxiety, process it, have it get better, and then the fuel for the eating disorder behaviors kind of disappears to some degree because they don't have the same response to those early past experiences, and they're able to cope and manage their own anxiety. So very quickly we try to get the benzodiazepines out of the way when folks come into treatment. The stimulants is another group. There's a reemergence of widely prescribing stimulants for attention deficit disorder, especially in adulthood. Folks with eating disorders are very bright, as you know, and they're on the internet all the time finding ways to live in their eating disorder even better. I have a large population of folks, past and present, that know that they can take Adderall or Ritalin and it'll help them lose weight more quickly. And even folks that truly have ADD and have had it since, when it's supposed to start at 7 or 8 years of age, know that they can use their stimulants and control their weight that way, and they oftentimes will take more and abuse it. But the issue is that in recovery from an eating disorder, I've learned it's very clear that a person needs to know when they're hungry and know when they're full. That's part of the recovery process and management process. If you're taking a diet pill, which is essentially Adderall, Ritalin, and those types of medications you're never really going to have a handle on when you're supposed to feed yourself, when you're hungry, and when you're full. So we really I try to get folks off the stimulants and onto something else that's non-stimulating or appetite interfering, because having that normal appetite exposed as it should be for your body is really critical for the eating disorder patient in recovery. And the other medication that I find as dangerous to the person with the eating disorder is topiramate, Topamax. It was a drug that came out as an anticonvulsant years ago. Major side effect was recognized early, which was weight loss. There were case reports early on when it came out and using it in bulimia, and lo and behold, for a short period of time, it seemed to help people with bulimia. It never got approved for bulimia, so my assumption is the drug company didn't promote the fact that it didn't work long-term for people with bulimia. But in any event, whether it does or it doesn't, it still has profound impact on the appetite, and even more so than stimulants, because the Topamax affects both ends of the appetite spectrum. It makes you less hungry, and then it makes you full faster than you normally would be feeling full. So for the person that's trying to adapt to a new meal plan that's healthy and adequate, knowing they're hungry, it's another drug that will interfere with the appetite in a way that could be very detrimental to the long-term recovery. And just as an anecdote, I've actually seen it be effective, the Topamax effective, early stages of bulimia, and then seen people coming in 2 or 3 years later, coming into treatment underweight, and the medication has never been stopped. So it's about thinking about when to use Topamax. If you want to base it on those early studies, which I think still are questionable, or those early case reports, there's got to be a point in time when you'd want to stop it after the behavior stopped, so that people don't turn into the anorexic phase. And we all know that people will shift between anorexia, bulimia, combination of the both, and even into binge eating disorder. So it's really important for those folks that may be using it in an acute phase of bulimia to stop it when they notice that there's a weight decline. So I'll turn it over to Debbie again.
So as we move down or progress in the step-down process through our 4 different levels of care, and of course this is ideal. This is assuming insurance will cooperate with us, the financial piece is in place. From an inpatient setting, we move to really partial care, and that's going to be maybe anywhere from a 7 to an 11-hour program per day. It becomes much more practical. They are going to still be operating according to the meal plan, but now they have just a little bit more independence. They're cooking as a group. They're planning meals as a group. They're learning how to shop and create grocery lists, brainstorm about food, and as well as serving others. All of these things from a dietary perspective for anybody with an eating disorder is difficult. So this puts them in a challenging situation. They're still doing the emotional, the therapeutic work that needs to be done in group and individual sessions, but the dietary piece very much is, again, at the foundation of the treatment and is the building piece for that. When they are moved down then to more of an outpatient, or what we call IOP, we're going to, again, have that same meal plan, and the meal plan may be adjusted as they stabilize. It just depends on the situation. They could have been doing so much restoring at an inpatient level, still needing to restore at the partial care level, and now they come into IOP, and they may stay there for a little bit, or we may move them down a little bit. If they're still restoring, it's possible that we may need to move them up. It just depends on where that patient is at. Regardless, we are trying to normalize the eating disorder, take the power away from the food, and what we really have to battle is that overconfidence that, okay, I've done so well in inpatient, I've been successful in partial care, now I come back to my regular environment, I'm in an IOP setting where I have a dietary once a week, I have a therapy session once a week, I've got group sessions in the evening, and this may really put quite a burden on the person because they're in their environment where perhaps nothing has changed, and really most likely nothing has changed. The hope is that they could have the people in their lives that are significant getting some care along with them so that the same type of pattern doesn't present itself all over again, and all the triggers are present, and now they are thinking that, no, I got this, I'm very confident, and they become overwhelmed. And what are they going to resort to? They're going to resort to their coping mechanism, the eating disorder. It's very comfortable because they're right back in that setting. So that intuitive eating, that mindful eating is not necessarily something that they can just jump into. We have to really work towards that. We are going to try to give them more comparisons to what normal, quote unquote, people might be doing, and that's going to include nutrition experientials, where we go out to dinner, where we cater in dinner, where we talk about food fears and we challenge them with foods. We have them doing their own grocery shopping. They are with their family or their friends, wherever they might have been living before. But oftentimes we find that the family and friends will have very unrealistic expectations, and they can play right into it, and they believe that this person is coming home fixed. And it's not that way. They have to have a lot of support. The family has to be on board. There needs to be family programming and ongoing attention to those relationships and the triggers that were within their setting and their environment. When we are talking about the success of a person and the ability to restore and maintain a healthy weight from the different levels of care, we just have to make sure they have adequate support along the way. So when you think about that meal plan, again, they're going to be encouraged to stay on that meal plan, however it's been adjusted or not, from that inpatient setting down to the outpatient setting. We want to work on the constant triggers that may be around them, how to look at that differently. That's where that emotional work is being done. To allow them to accept setbacks, that this is part of the process and that they have to know they're in the real world. Things haven't changed necessarily. The same ads on TV, the same school, stress, work, family, job type of triggers that they might have had before. So we have to be able to encourage them to stay consistent with all the things that they were doing at a higher level of care. It can be a very slippery slope. They get busy. Oh my gosh, I got so busy at work, I don't have time for my snacks. All these excuses and distractions from following the meal plan will definitely play a role in their ability to stay in recovery. So we work a lot on that and letting them know that that's a very slippery slope and they can't jump in very fast. They might need to ease back into work, doing a few hours a day and then moving into full-time if that's what they were before. The other problem that we see a lot is we'll get students or children, like adolescents, that will come and the parents will say, well, we want them in your program for the summer. It's almost like it's summer camp. That's not how an eating disorder works. That's not how we're going to be able to take that eating disorder mentality and help that patient to be in recovery, in a solid recovery. They're likely going to go right back into it. So we really have to take a look at all the factors that's going on in their environment to be able to help them for a long-term success.
On the outpatient side, looking at the person that's come through different levels of care to get back on their feet and continue care. It says primary role, but one of the big roles that I try to play is to make sure that the patient's listening to the rest of the treatment team, that they're following the meal plan as outlined by the dietitian, they're exercising or not exercising to the extent that the dietitians are advising at that point once they reach outpatient. There's some indication that the first sign of relapse now with new research is people starting to exercise, and I'll often get a question from the family, how do we know when we should, when our loved one is exercising, when they were a compulsive exerciser as part of their eating disorder? And my answer uniformly is, did the treatment team or the dietitian give permission or a plan to start exercising again? And if a person is doing it outside of the recommendations of the team and the treatment providers, that's worrisome. So folks that are working with eating disorders are usually very aware and asking the exercise question and giving direction to get people, especially over-exercisers, back into an exercise regimen when they're appropriately ready to do that. And my experience, it can take several years till the person that was a compulsive exerciser is ready to start dabbling in exercise again. And I'm always asking about abstinence from behaviors and getting feedback from the rest of the team. And once I hear the behaviors are back, or they're off the meal plan, I really believe that my ability to do much more of anything, including monitoring comorbid psychiatric symptoms and assessing whether medications need to be adjusted or not, are markedly limited because it can all be affected by either the lack of nutrition from the meal plan, not doing the meal plan, or recurring binging, purging behaviors and exercising behaviors. So I'm really looking for those things happening when I see a mental status change, and when they are, my goal is to work with the patient to get back to abstinence and on their meal plan, and then I can make an assessment as to whether their depression needs a change in medication. Oftentimes not. It's getting back on course with the rest of their treatment program. I believe in that so much is that I often recommend to patients and families that they see the dietitian several times if they're coming out of a protective setting, if they're coming out of a inpatient or residential setting, or even a partial and very structured partial program, and now you're in the outpatient setting where you're only seeing the professionals once a week. If that, I really believe touching base with the RD on multiple occasions, at least for the first few weeks, to assure the person's able to do their meal plan and following it is really important, because my experience again says that's kind of the first thing that will start to slip, and it can slip pretty drastically. And once that starts to go, until we get it back on track, they might go all the way back to the point where they needed residential or inpatient treatment again. We certainly hate to see that. Again, I continue to talk about, yes, that you have a comorbid depression, and the Prozac or the Cymbalta or the Effexor or whatever we're using has been very effective, but it's been effective while you've been in abstinence and your nutritional status has improved. It's not going to work as well if you continue those behaviors. And folks will keep coming back and asking and thinking that a small medication adjustment is going to make a big deal, and it really, in my experience, doesn't, as long as the meal plan's not being followed and the behaviors are out of control. So what am I doing with again, I have the advantage of working in our inpatient residential setting, in our partial hospital program, and in our outpatient program in our Tempe office. So I follow people through all levels of care. What I'm doing when they finally get to the outpatient and IOP level of care and they have more time in the real world, number one, I'm treating if they have a comorbid depression, which is not uncommon. I'll be looking at symptoms for any changes in mental status and monitoring their antidepressant medications and any other medications they may be taking concurrently, making sure if they have a history of substance abuse that they're staying clean and sober and they're not drinking, and following those plans, and if they truly have an addiction, that they're going to the meetings regularly and they're getting support from that. looking for new stressors. Obviously, when somebody gets to the outpatient level and life starts to intrude, it gets much more stressful. So I'm assessing for what new stresses do you have and how you're responding to it. And it's always wonderful to see a new stress at school or something, or finals are coming up, and guess what? I'm staying on my meal plan and I haven't used my behaviors, and I'm calling my peers for support and doing things that I didn't do prior to getting into treatment that's keeping me on course, and encouraging people to continue to use those healthy coping skills. Again, the exercise piece, I just want to mention again that it's sometimes, even though it's one of those things that are healthy for most of us, can be dangerous for the eating disordered person to start them back into the relapse, so I'm asking questions about that too. So in summary, what I've learned as a psychiatrist working in eating disorder specialty areas, that dietitians are really important, that I can't do their work, and I'm looking to them to make sure that the nutritional status has improved to a point that I can count on my assessment being accurate. Take the malnutrition into account for the psychiatric symptoms, and that's important to come to an accurate psychiatric diagnosis, because without a good diagnosis, your treatment's not going to be effective and correct. So with that, we will end the webinar.
Thank you, everyone. I want to thank you for taking time out of your busy schedule to join us today. I want to thank Dr. Karp and Debbie for joining us. As well, I want to let you know that you will be receiving an email shortly after you stop hearing my voice, and it will tell you exactly what you need to do in order to obtain your continuing education certificate. We are out of time, but if you do have questions, please feel free to send your questions to tri@rosewoodranch.com. Thank you and have a good day. Bye-bye.